used crazy glue.
Yeah, it looks that way.
What? This is ridiculous. Hello, my name's Ed, your friendly neighbourhood emergency doctor, and I'm fresh from a bunch of night shifts, so anyone asking why I look so tired, yeah, it's because of that. And so to relax, I like nothing more than kicking back and watching other doctors stress in the emergency department, so here it is, my reaction to episode 2 of The Pitt. We are right back into it with the pandemic flashback scene. And we see a team rolling the patient so they can spend time on their front, what we call the prone position. This helps the oxygen levels of the patient by using gravity to pull the fluid in the lungs to a more favourable position. We also encourage patients who weren't ventilated but needed oxygen to lie in this position too. You might think that's quite a lot of people to roll one patient, but you have to be so careful that you don't dislodge that endotracheal tube when rolling the patient, because the lung inflammation in these patients is so bad that they deoxygenate rapidly within seconds and can arrest on you.
Signs of trauma?
Nothing.
Okay, open your eyes, Nick. On 3. 1, 2, 3.
This is such a nitpicky thing to point out. I can already hear the groans in the comments. But when we move patients, we are taught to say ready, steady, go, or ready, steady, slide, whatever action you're doing. It's just clearer for everyone when you actually do the movement. I know she told everyone to go on 3, but some people automatically would go on 1, 2, 3, and then move, effectively going a beat after everyone else. Like I say, it's a small thing, but it's super important to get instructions like this timed properly. As if the patient has a spinal fracture and we're trying to immobilize the spine, we need to move them in a smooth manner to prevent unnecessary movement that could potentially damage their spinal cord.
Heart rate 64, BP is cycling.
No response to pain, GCS 3.
So a GCS of 3, that stands for the Glasgow Coma Score, which is where we assess the patient's alertness through assessing their eyes, their voice and their movement. It's a score out of 15, so my score now would be 15 because I'm alert, my eyes are open, I'm talking coherently, I think, and I'm able to move to commands. The patient here has a score of 3. You may think that's something. Well, no, 3 is actually the lowest score, so pretty worrying. And his pupils aren't reacting to light.
Pupils are 6 millimeters, non-reactive.
We touched on this a bit in the last episodes. This indicates injury to the brainstem, where many of your critical life support functions are controlled. So this is a very poor prognostic indicator.
Could use a latte though.
Well, that could bring back the gallstone pain.
How about a bourbon?
It's barely 8 o'clock. How about some ice chips?
So clearly he is joking around about having some whiskey here, but this isn't so mad. You can have odd things that we prescribe on the drug charts. I worked on a ward where we had a chap with terminal cancer that was in for several weeks, and we prescribed him a glass of wine for whenever he wanted it because he liked an occasional drink and to read the newspaper in the evening.
Your father has pneumonia and a condition called sepsis.
What is that exactly?
It means that the bacteria has spread from his lung to his bloodstream. So far, he's been...
What? Dr. Robbie, have you not watched the last episode? I found sepsis to be poorly understood by the general public, who often think it's an infection in your blood. In my last reaction, we said that sepsis is not bacteria in the bloodstream. We'd call that septicaemia or bacteremia, the suffix emia meaning something to do with the blood. Sepsis is not the bacteria spreading in the blood, but your activated immune system from the site of infection spreading around your blood. And this ends up causing hypoperfusion, so lack of blood supply and oxygen to your organs. Clearly, Dr. Robbie should know this, but an explanation rather than the writing team making a mistake is that sometimes as doctors, we do simplify things when talking to patients. For example, I worked with a consultant that described a pneumonia to a patient as a lung infection so bad you see it on an x-ray. Now, you wouldn't get any marks at med school if you wrote that, but you know, from a patient's point of view, it gives them everything they need to know.
How we doing, Ben?
One. Back in my throat.
That's probably from the nosebleed. Short, rapid rhino, please.
Tacky 1.
Oh, we're gonna see a rapid rhino. Are you guys ready? This is essentially a tampon we inflate up someone's nose to stop the bleeding. It's important to stop the bleeding in this patient because they're immobilized on their back to protect their spine, and so any bleeding is going to go into the throat and potentially cause airway problems. That's why here we can see they've been using suction. You may think, therefore, a rapid rhino in this patient is a no-brainer, but you need to be very cautious packing the nose in this case. And I'm surprised they haven't at least mentioned that he may have a base of skull fracture, and you don't want to accidentally push the packing up into the brain. That would be very bad. Although, just watching this back, in fairness, they do mention there's no hemotympanum.
No hemotympanum.
This is where you have blood building up behind the eardrum when you look into the ears. This is a sign of a base of skull fracture. But in this patient, I don't think they have much of a choice. They need to put the rapid rhino in, given the fact that blood is going into the airway. And the only way to confirm what's happening with the skull is to then CT him. So you need to control the bleeding into the airway before they'll get him in the scanner.
Inflate the balloon.
How about now, Ben?
Better.
Yeah, great. As they say here, they inflate the balloon with a syringe to apply pressure inside the nose to encourage the blood to form a clot. They got this rapid rhino in seconds. Usually takes a few minutes to get the rapid rhino kit, soak it in water, and then apply it. And that seems to be a common theme throughout everything here. Everything's happening super quick, which ideally you want, but maybe in reality doesn't happen quite that rapidly. So in reality, maybe a rapid rhino is more like a fairly rapid rhino.
Better.
What's up?
Good vitals, A&O. Let's have a look.
Wow. A floating face. I have never seen that.
Floating face.
Report 3 fracture.
You don't see that every day. Oh,
I love how excited the surgeon is by this. A Lefort 3 fracture. I mean, I'll just have to take their word for it. But essentially, for this to happen, the middle of the face has broken in a few places and caused it to separate from the rest of the skull. We see facial fractures on most days, but never anything this extreme.
okay, let's prep for an airway. Double setup just in case.
With the loss of structure to the face from the severe facial fractures and the potential to swell even more, the airway is at risk, so they've opted for a definitive airway, so they're going to intubate the patient. And they mention here a double setup means, as well as the standard orotracheal tube, they're also getting an emergency airway kit ready too. So in difficult airways like this with facial injuries, there is a higher chance they may fail to get the tube in when the patient's put under, in which case they have the emergency tube ready to put instead. This is what we call a surgical airway or a cricothyroidotomy, because we make an incision in the cricothyroid membrane. I was instinctively faffing around on my throat there, but you can feel the cricothyroid membrane yourself. And that's if you go down the hard thyroid cartilage, there's a little gap, a little membrane before you hit the hard cricoid cartilage, and that's the membrane we go through.
What's that?
It's a drug test, and it is positive for fentanyl. Can we move Nick Bradley to a private room?
Like you're gonna make it?
Oh man, so yeah, a real sad one. So the young man with a GCS of 3 has a normal CT, so no large stroke or bleed, and they suspect he's had a hypoxic brain injury as a result of fentanyl overdose. So this could have been deliberate or accidental. Fentanyl is a very strong opiate, so just a small amount he'd lose consciousness, so he wouldn't be maintaining his airway, and it also slows your breathing, both of which would result in your brain not getting enough oxygen, and your brain can be dead in as little as 5 minutes. I've seen some bizarre footage online of people being near fentanyl or touching it and then passing out. It's nowhere near that strong or that easily absorbed through your skin. We use it in hospitals all the time, and we aren't passing out. You're only going to get an effect from it if you purposefully inject it, have it in your mouth, or spray it up your nose.
Any luck getting our psych boarders upstairs?
Yeah, right. At least the Kraken's still sleeping.
I think what a lot of people are liking about the show, and me included, is the level of realism that it shows here. But you really don't want it to be completely real, because there are many aspects of our working day that is pretty monotonous. And because of this, one of the only things that isn't that realistic so far is they're not showing anywhere near the amount of admin we have to do. I've had quite a few young people shadow me as a doctor to get some work experience, and they always are so surprised how long we spend at a computer doing admin tasks, mainly writing up patients' notes, but also looking up guidelines or requesting and reviewing results or referring to specialists in other hospitals. And all these systems can be really clunky to use.
Possible foreign object in the eye, which is always a solid 7 on the WMMV scale. What makes Mateo vomit?
You okay?
One of the top comments from the last video was that they appreciated how realistic the show was because we didn't have people sort of having relations in the store cupboard. Well, maybe we spoke too soon. There's a little bit of tension going on here.
That's the thing about emergency medicine. You never know what you're gonna get, and we get everything.
Is that why you chose it?
Maybe a little. I also get to pick my shifts, which for a single mother is amazing. But mostly, I just like the people.
Yeah, so Dr. McKay talking about why she likes to work in the emergency department, and I can totally relate because we need to cover all hours. We can effectively book our shifts whenever most suits us. Another pro is that you don't take your work home with you. Obviously, psychologically, the patients may stay with you, but you don't have the responsibility for them. You either refer them or discharge them. Whereas other specialties, you may have a caseload of patients that you look after for weeks or months, or in the case of family medicine, their whole lives. And you also don't have clinics or surgeries or other things booked into your schedule months in advance, which I would find, particularly kind of stressful, like in a chronic way. And as Dr. McKay said, I also like the fact you work with every type of person. So all different members of the hospital team, from people's first jobs as teenagers to highly skilled nurses and other staff. But you also then serve every type of person that comes through the door. So it gives you a really interesting and diverse life experience. I would list some of the bad points too, but how long we got? What the hell? She's got an ankle monitor. Any kind of criminal activity you get embroiled in your life, you have to notify your licensing body and will result in a fitness to practice. So they'll assess your ability to work as a doctor, potentially suspend you, or even take your license away. So yeah, if you were thinking about being a doctor and a part-time criminal, think again.
Smell the alcohol from here.
This guy's wearing the spring, summer, and fall collection.
Okay, I did not expect the rats. Never seen that before, but never say never in medicine. The animals I've seen include a therapy cat. I've seen a guy with maggots in his wounds. I've also had on the ward, a kangaroo come over to make the patient smile. But never a patient hoarding rats. I'll tell you what though, rats are famous for carrying Weyl's disease, so stick that in your differential diagnosis.
Hello, I'm Kiara Alfaro. I'm the department's social worker.
Kiara will help you navigate the next steps.
What steps?
Well, a case like this requires mandatory reporting to child services and sometimes law enforcement.
This is a situation that happens all the time, so most emergency doctors would be familiar with this.
No.
Why do you have to involve the police?
It's a controlled substance.
They're not taking my kid away.
They were pot gummies.
Well, your suggestions. No one is touching my child.
Yeah, and reactions like this, yeah, I've heard it happen. Thankfully, it's not happened to me, but you can understand where the parents are coming from. They are feeling judged and accused. It's all in the communication with how you tell them. And I just say to the parents that this isn't about your child. It's about protecting all children. So any injuries that present like this get referred to child safeguarding, no matter what. So no child slips through the net and we don't miss that one child that really needs it. And usually the parents aren't happy about it, but they understand where you're coming from.
He's been uncooperative and combative since we picked him.
Let her go.
Stop fighting. Come the down or I'm calling the cops.
My meds at home aren't working. Please, I have sickle cell.
Okay, stop. Everybody stop.
Do you know what? I knew she was going to have sickle cell. The last patient I saw in this kind of pain present like this had a sickle cell crisis, an intensely painful condition. So sickle cell disease is a congenital abnormality of your red blood cells, making them crescent shape instead of the typical donut shape. And in a sickle cell crisis, these block your blood vessels, starving your tissues of oxygen and causing immense pain. So this patient here needs urgent IV morphine, they need oxygen, they need fluids, and they need to come into hospital.
And he yaps all day long. And when I woke up, I was wearing it. Stupid bitch! Go.
Sorry.
I think she must have used crazy glue.
Yeah, it looks that way.
What? This is ridiculous. I mean, you see mad stuff in A&E, but I mean, I think, is this teetering on the fictional? I don't know. The last major glue incident I saw was someone who glued their eyelids shut whilst trying to put on fake eyelashes. That took a lot of patient snipping.
I guess your skin cells on your neck will naturally slough off, and you should just be able to remove it in time.
How much time?
What? You would not send this guy home. You would 100% remove that collar.
Yeah, I got stuff.
Can you guys help? What's your name?
2 units of whole blood going on the rapid diffuser.
Call the OR, we'll be right up.
Lungs up.
Do you take medications every day? Any allergies?
No. Morrison's a full blood. See that?
Yeah.
We have a young chap with a gunshot wound to the abdomen. Here, Dr. Robbie is doing a fast scan while Dr. Garcia is taking a quick ample surgical history. Dr. Robbie finds there is blood in Morrison's pouch. So this is the area between the kidney and liver on the right side of the patient. And when someone is lying on their back, this is the lowest dependent space in the abdomen, meaning any fluid collects there with gravity. In this case, there is blood collecting there. So this guy needs an emergency laparotomy, so it needs to be opened up in the operating room. And so Dr. Garcia is taking an ample history. So this stands for allergies, medications, past medical history, last meal, so the time of their last meal, and any events leading up to the injury. This is all vital information for general anesthesia and surgery.
Mr. Milton? Hey, Bennett, wake up for me. Oh, shit.
Dude, what is happening in this emergency department? We've got another cardiac arrest. I promise you, it's not really like this.
I need a little help here. Help! When did you check on him last?
Cool. Okay, well, we've improved a little bit with our cardiac arrest compared to the last episode because he immediately calls for help and he immediately starts chest compressions. Very good.
I got it.
Oh, compressions?
Okay, we had a good start, but these chest compressions, yeah, they're not great. They don't look like they're compressing the chest at all, but clearly this is a real person and not a mannequin, and you should never do chest compressions on someone for practice. So yeah, I've got to kind of let them off that one.
Asystole.
Resume compressions. Amp of epi.
Shit. Asystole. Never what you want to see. The flat line. So no electrical activity from the heart. This rhythm does not respond to a defibrillator, so no shocking this patient, despite what you may have seen in other TV and films. We just continue chest compressions and ventilating the patient, and we give them some adrenaline, and we try to reverse any causes that might have led to the cardiac arrest. The aim being with some oxygen and a kick up the backside from adrenaline and correcting anything that caused the arrest, the heart may leap into action. All cardiac arrests are bad, but asystole is the worst of a bad bunch.
Pupils are fixed and dilated.
Been down a long time.
Oh man, poor kid. This is only Whitaker's first day in the emergency department and his patient arrests and dies. I've had something similar happen to a friend of mine. This was their first week as a doctor and the patient died and it affected them a lot. And there's probably nothing they could have done about it, but at that point in your career, you don't have the resilience and experience to be able to process it properly.
We switch out every few minutes. You can take a break.
I'm fine.
Hold compressions.
Chest compressions are knackering, particularly when you're doing it like this. So the technique here is not good. So either the bed needs to be lower or he needs to stand on a stool, because you need to get your shoulders over the patient so you can lock your elbows out. And the chest compressions do not come from the arms. That is just going to tire you out. It comes from your hip flexors, you know, these big muscles here, and that allows you to deliver them more effectively. And because he's getting tired here, he should be forced to switch out and let someone take over, because even perfect chest compressions only generate a systolic of around 80, so only just enough to sustain life. So any poor performance is going to result in a worse outcome for the patient, although it's not looking like it's going to make much difference in this patient anyway. Also, one thing here, why are the curtains to this bay open here? Just so everyone in the department can see. You know, we really need to preserve patient dignity here.
What? I gotta go tell those parents their 18-year-old son is brain dead.
You want me to come with you?
Nope. It's okay.
What are you gonna say?
I'm going to say that it's likely, but we still need to do an apnea test and a cerebral perfusion study.
There's no cranial nerve activity.
Those people need some hope.
False hope.
Yeah, I mean, we talked before that there's way more cardiac arrests happening in this show than would actually happen in real life. But they still happen. We still have to have these conversations, and you just have to give the information as accurately as you can. You know, giving false hope is not a good idea.
You can wake him up. You can do that. You can stop. You can stop him.
Oh man. Yeah, well, all I can say is that this reaction is very realistic. So there you have it, another super episode of The Pit. And I think Dr. Robbie is a freaking legend. I think I'm going to get a tattoo for work that says WWRD. What would Robbie do? And thank you so much for all your support on the last video. It's been a while since I've had one do quite that well, so I really appreciate it, and I hope you've enjoyed this breakdown too. And if you have, please consider subscribing. It really helps me build the channel. And leave me a comment if there's anything in this episode I've missed or any other shows you want me to check out. I hope you're all well, and I'll be back soon.